Good afternoon, everyone, and welcome to day 3 of Children's Week. We are so glad you were able to join us this afternoon for our session. My name is Kimberly Williams, and I am the Director of Operations of the Bass Childhood Cancer Center at Stanford Children's. So again, welcome. A few housekeeping notes. First, this session awards both CME and ANCC credits, and you'll receive an email tomorrow from the Stanford CME office with instructions on how you can access your credits if you're interested. Please use the Q&A button at the bottom of your Zoom screen and send questions to our speaker, and we'll be able to facilitate those questions. So today's session is on the care options for gastroesophageal reflux disease. And so we are very pleased to have Dr. Ari Moon with us for this session. So just a little bit about Dr. Moon. So Dr. Moon is an adjunct clinical associate professor of pediatrics, gastroenterology at Stanford University School of Medicine. She's also the medical director of the Pediatric GI and Nutrition Program in the North and East Bay. So in 2022, Dr. Moon was named one of the top doctors list by San Francisco Magazine, which is quite an accomplishment. She received her medical degree from Catholic University Medical College, her residency at SUNY Upstate Medical University, and her fellowship at Harvard Medical School. She has over 30 years of experience in the medical field, and we are so excited for her to share her knowledge with you all today. So welcome, Dr. Moon, and I'll turn it over to you.
Thank you so much. That was a great introduction. Good afternoon, everyone. Before we start, I would like to thank the organizers for inviting me to speak today. It's an honor. The title of my presentation today is Gastroesophageal Reflux Disease in Pediatric Patients. We have 1 hour for the presentation and followed by a 30-minute Q&A.
Dr. Moon.
Looks like we're unable to hear you, Dr. Moon.
Okay.
Just for a quick second, but yeah.
All right. So we have 54 slides to present, and if everything goes as planned, I think we could finish early. So if you don't mind, please save your questions until the Q&A session. Let's get started. Full disclosure and nothing to report. These are the learning objectives of my talk today. Hopefully, we could accomplish all of that. Just in case, for those of you who are not familiar with this, I'll be using these abbreviations throughout my presentation today. What's the difference between reflux and reflux disease? In clinical practice, it may be challenging to differentiate simple reflux from reflux disease in children. Most often than not, these terms are used interchangeably by healthcare professionals as well as parents. Reflux is a normal physiologic process occurring at all ages. Reflux disease is a pathological condition that could lead to troublesome symptoms or complications. Reflux typically occurs after eating, and it is relatively short-lasting, perhaps less than 30 minutes or so. Most patients with a simple reflux are asymptomatic or have very few symptoms. It could cause vomiting, that is forceful expulsion of gastric contents. Regurgitation is the most visible symptom of reflux. Unlike vomiting, regurgitation is not forceful, and it could cause spitting up in babies. This father came up with a very interesting creative solution for his baby's vomiting issues. And I hope this dog likes what he's eating. It appears that the prevalence of reflux disease in infants has gone up in the past 2 decades, or the media coverage of Gerd in infants has gone up. We don't know. They describe inconsolable infants dramatically improving on PPI therapy. There has been a tremendous rise in use of PPIs in children over the past 15 to 20 years. In addition, there has been frequent off-label use of PPIs for infants. Just want to let you know, there's only one FDA-approved PPI that can be used for infants. That is esomeprazole. Lansoprazole, omeprazole, pantoprazole have been approved for children 2 years and older. However, liquid form of omeprazole, lansoprazole have been frequently prescribed for infants. Many pediatric GI folks, myself included, have been using this medication for infants quite often. So this practice pattern raises some question, and we have to ask ourselves, is reflux in babies more common than it used to be? I don't think so. Are we simply recognizing a problem that's always been there? Perhaps. Are we over-treating reflux in babies? Are we over-prescribing PPIs in babies? I think the answers for both questions are yes. I will come back to this later in the presentation. Let's talk about natural history and physiology of reflux and reflux disease. This is a very well-known study from 1997 by Suzanne Nelson. She's a friend of mine from fellowship. This was a cross-sectional survey completed by 948 parents. This study showed that the prevalence of rate of regurgitation at least once a day. Let me just get the laser point. Okay, so at least once a day was 50% between 0 to 3 months of age. That peaked at 4 months of age to 67% and dropped dramatically down to 5% between 10 and 12 months of age. So what does this mean? These findings support the concept that reflux in most infants is a physiologic and self-limited condition. Therefore, we don't have to be overly aggressive with managing simple reflux in infants. What is natural history of reflux? This is an impressive Australian study by Martin from 2002. They follow a total of 693 children from birth to 9 years. So the study confirmed that reflux symptoms are very common during infancy, and the vast majority of infants improve by 13 to 14 months of age. We knew that already. But this study also provided some new findings. They identify a few predictors for future reflux symptoms since they follow babies from birth to 9 years. So infants with a persistent reflux disease lasting more than 90 days are more likely to have reflux symptoms at 9 years of age. So these findings support the notion that reflux disease is a lifelong disease. Babies with a reflux grow up to be adults with a reflux disease, sometimes with complications. Other predictors they pointed out included exposure to smoking, that's before and after birth, maternal history of reflux symptoms, suggesting a possible genetic component. So this is from an adult study. It may not be completely relevant to pediatric population, but I believe this gives us some idea about natural history of reflux disease. There are two main forms of reflux disease. One is NERD, stands for non-erosive reflux disease. The other one is ERD, stands for erosive reflux disease. The majority of reflux patients, up to 70%, have NERD, not ERD. So that's a good thing. There are two schools of thought. One is categorical disease hypothesis. The other one is a continuous spectrum disease hypothesis. So first one, categorical disease hypothesis means patients tend to remain in the same class throughout their lives. Therefore, they are focusing more on symptom control rather than endoscopic surveillance. The next one, continuous spectrum disease hypothesis means patient can pass from one to another class. So there's a risk of disease progression, and therefore they are focusing more on endoscopic surveillance. Some studies in adults have shown that most people with a NERD and mild esophagitis tend to remain in the same class, and the progression from NERD to ERD to Barrett's esophagus occur in a relatively small number of patients, but it's not zero risk. So if initial endoscopy shows severe erosive esophagitis, typically these patients get treated with a PPI for symptom control, as well as to prevent the progression to Barrett's esophagus. And these patients also get surveilled. So they do a little bit of both, symptom control and as well as a surveillance. And this is what we do for pediatric patients as well. So who is at risk for developing severe reflux disease? Acid reflux is more common in patients with a cystic fibrosis because of the following reasons. Their hyperinflated lung from obstructive lung disease could push down on the diaphragm, and their frequent coughing and wheezing episode worsen acid reflux or reflux in general. These patients tend to consume high caloric, high fat diet to offset malabsorption, and that's not good for acid reflux. They often have delayed gastric emptying, so that's also not good for reflux, and potential side effect from multiple medications they have to take. And also lastly, chest PT position could trigger reflux. Esophageal atresia repair patients are also at increased risk for reflux disease. Virtually all of these patients have esophageal dysmotility, causing them to have delayed acid clearance, delayed food clearance, and at the same time, esophageal narrowing at the anastomotic site also occur in this patient. And hiatal hernia often created during TEF repair surgery. Neurologically impaired patients tend to have poor muscle coordination, delayed gastric emptying, and dysfunction of enteric nervous system. And fundoplication may not benefit this population due to high morbidity and failure rate. So it's not uncommon for them to have another fundoplication after their initial fundoplication surgery. Obesity clearly increased the risk of reflux disease, and family history matters. Like I said, family history does matter. So there are a number of publications showing increased familial concordance for reflux symptoms, hiatal hernia, erosive esophagitis, Barrett's esophagus, as well as some cancer. Severe pediatric Gerd might be associated with a chromosome 13q14 locus. Chromosome 9 locus might be associated with an infantile esophagitis. So let's talk about anti-reflux barrier. There are several structures at the gastroesophageal junction. They are crucial in maintaining this barrier. The most important one is lower esophageal sphincter, and that constitutes the major anti-reflux barrier. The next one is phrenoesophageal ligament that anchors the distal esophagus to the diaphragm. And the last one is the angle of His. That is an acute angle between the cardia and the esophagus. So in infants, when compared with the older children and adults, their lower esophageal sphincter is much shorter, 3 to 4 centimeter in adults versus 1.5 centimeter in infants. and their angle of hiss is not as acute. So why is acid reflux more prevalent during infancy? This is all about anatomy. We just talked about their LES being shorter and their angle of hiss being less acute. As if that was not bad enough, there are more reasons. Their esophagus is much shorter, 10 to 11 centimeter versus 25 to 30 centimeter in adults. Their gastric capacity is very small. It could accommodate only up to 10 cc of volume. And their recumbent position, meaning they're lying down, there's no gravity helping them. And all these factors work against them and make them more susceptible to reflux. Although it is debatable, some studies suggest that they have poor gastric compliance and delayed gastric emptying, and that certainly could play a role here. Why does simple reflux becomes reflux disease? Before we go there, we have to understand the primary mechanism for reflux. That is transient LES relaxation. It's not about lower LES tone. We used to think that infants have a lower LES resting pressure that made them more susceptible for reflux. Now we know their esophageal sphincter pressure is just as high as older children and adults. So transient LES relaxation can occur in healthy individuals as well as a patient with a reflux disease. The main difference is patients with a reflux disease have more of them frequently. Transient LES relaxation is normally vagal nerve mediated, and it is also triggered by gastric distension. Esophageal acid clearance is an important defense mechanism. It consists of peristaltic movement and neutralization of acid by saliva. We talked about delayed gastric emptying and poor gastric compliance not too long ago. And the last one is, although esophagus has a very impressive tissue resistance, but there's a limit how much they could tolerate. If there's a constant acid exposure or non-acid exposure from bile, pepsin, pancreatic enzyme that are very damaging to the esophageal tissue, tissue resistance no longer works, and it could actually lead to erosions or ulcerations. Signs and symptoms of reflux disease. Different age group has different presenting symptoms. Common symptoms of reflux disease in young children include excessive regurgitation, feeding refusal, feeding difficulty. Older children might have anorexia, and they are fussy. They cry all the time. And some can have choking, gagging, coughing, and they don't sleep at night. They cry. And they could also complain of abdominal pain if they're a little older. In older children, their symptoms are very similar to symptoms in adults. Esophageal injury can lead to reflux esophagitis, reflux-related stricture, Barrett's esophagus. Cancer is not as common in pediatrics, thank God. So in infants, excessive crying and fussiness does not necessarily mean reflux esophagitis. There's a poor correlation between irritability and actual histological changes. So in this case, what you see is now what you get. However, when it comes to feeding difficulties and feeding refusal behavior, there seems to be a better correlation between their presenting symptoms and some degree of esophageal injury. So what does that tell you? We need to pay close attention to babies with feeding issues and poor weight gain. Okay, there are definite associations and possible associations when it comes to extraesophageal associations. Sandifold syndrome and dental erosion are known to be associated with a reflux disease, and I will talk about Sandifold syndrome shortly. Reflux disease has been blamed for many symptoms in infants, without good evidence to support that. It has been implicated as a cause of asthma, either directly from aspiration or indirectly from vagal nerve-mediated bronchospasm. Reflux disease has been also associated with a chronic laryngeal symptoms such as hoarseness, chronic cough, chronic laryngitis or pharyngitis. So far, a link between reflux disease and all these conditions are inconclusive. Sandifold Syndrome is a neurobehavioral disorder that causes a series of paroxysmal dystonic movement of head, neck, and back arching, and it is often mistaken for epileptic seizures. And clearly, it is associated with a gastroesophageal reflux in some cases with hiatal hernia. So not all vomiting episodes are GERD related. So when do we suspect non-GERD related problems? Here are the red flag symptoms. Failure to thrive might indicate systemic conditions. Forceful projectile vomiting and bilious vomiting may suggest anatomical abnormalities such as intestinal obstruction or malrotation. Hepatosplenomegaly might suggest some types of viral infection, just like Epstein-Barr virus, congestive heart failure, or end-stage liver disease with a portal hypertension could do that, and malignancy like lymphoma, and some types of storage disease such as Niemann-Pick disease. Late onset worsening vomiting after 4 to 6 months of age always worries me, because by this age, you would expect them to get better, not get worse. So differential diagnosis for that should include, they could have UTI, they could have food allergy, but the concerning thing is CNS related. Do they have tumor? Do they have hydrocephalus? Things like that. If they have more obvious signs like a bulging fontanelle or nocturnal vomiting or funky shaped head, then it's definitely CNS related. Constipation, we need to suspect Hirschsprung's disease, milk protein allergy or celiac disease or hypothyroidism. Diarrhea, we need to suspect viral gastro or milk protein allergy, other malabsorption such as a celiac disease, and sometimes very early onset inflammatory bowel disease can cause diarrhea too. Vomiting undigested food, we need to suspect food allergy / intolerance, gastroparesis, or rumination. Reflux-related complications include esophageal stricture and Barrett's esophagus. Esophageal stricture can be easily identified at Barron contrast. You could see this narrowing here. And this test must be performed prior to endoscopic examination. Endoscopic examination will show narrowing of esophageal lumen in the worst case scenario, just like here. You could see a pinhole size esophageal lumen. In this case, even our neonatal scope will not go through. And these patients require esophageal balloon dilation. The bottom picture shows very irregular GE junction, which is a gastroesophageal junction. You could see those pink mucosa, that's esophageal mucosa, which is a squamous epithelium. And this salmon red mucosa is a gastric mucosa, which is a columnar epithelium. So we call squamocolumnar junction here too. So in Barrett's esophagus, as a result of chronic acid exposure in the esophagus, intestinal metaplasia occurs, and esophageal mucosa is replaced by the gastric mucosa. So you could see this is start to move up. Diagnosis of reflux and reflux disease. It goes without saying that we need to do a thorough history and physical exam. And this is the list of diagnostic tests we could consider. I will discuss each test separately in the following slides. I think this history taking process is extremely important. I consider this as a detective work. Just like they interview their witness and suspect, we interview our parents and caregivers. We have to be really detail-oriented. Otherwise, we will be missing a lot of relevant information. Just remember, not everyone is going to volunteer the information unless asked. So these are the questions we typically ask. What are you feeding your baby? How often, how much, and what is the total volume per day? How do you mix and how do you prepare your baby's formula? Any changes in maternal diet if breastfed? Have you introduced new food items? Any new formula introduction? What's the position of the baby during and after feeding? Do you burp your baby? If so, and how often? Baby's behaviors during and after feeding. And in terms of pattern of vomiting, you could ask, how often does the baby vomit and how much is coming up? Any pain associated with the vomiting episodes? Are they forceful or projectile or non-projectile? Are they bilious? Any visible blood present? If so, how much blood? Any history of fever, lethargy, or diarrhea? Do you see digestive food or undigested food coming up? Does the baby sleep at night or wake up frequently and scream? Those are the questions we have to ask, and we'll give you a lot of information about what's going on. And I think this picture speaks for itself, so I'm not going to comment on this. Upper GI series is a useful test for detecting anatomical abnormalities, and that is the one and only reason I would order the test. It is not a reliable test in differentiating physiologic versus non-physiologic reflux episodes. Obviously, radiation exposure is concerning for young patients. We used to do this test a lot, pH monitoring, maybe 20 to 25 years ago. It has become an obsolete diagnostic test. The main problem with the pH monitoring is that it only detects acid reflux. It does not detect non-acidic reflux. So we changed that. So combined pH impedance test was developed in the early 2000s, and it is considered the gold standard test for evaluating reflux burden. The main strength of this test, as I mentioned, it detects both acidic and non-acidic reflux episodes. It is able to differentiate reflux from regular swallow, and it accurately detects the height of the refluxate, meaning how high does it come up? Is it up to the proximal esophagus or posterior pharynx? It will tell you. This test is performed and read by motility specialists, and I don't read this test. The main advantage of upper endoscopy is that we are able to visualize and obtain biopsy samples. The prevalence of erosive esophageal is much lower in children compared to adults. Many patients with a persistent reflux symptoms have normal endoscopic examination, but we have to remember, even with a grossly normal endoscopic examination, sometimes we do see microscopic esophagitis. Of course, the downside of this test, it is invasive and requires general anesthesia, and potential procedure-related complication can happen, although rare. So management of reflux and reflux disease. The bottom line is we don't do anything for thriving happy speeders. So if I were to see this baby in my office for reflux, I would not do anything. There are 3 management options. When we manage patients with a reflux disease, we generally try a step-up approach, meaning we should always consider conservative management as a first-line therapy. Conservative management means non-pharmacological therapy. The next step is trying some medication, The last option is surgical management. We see many new moms and dads. Understandably, they could make some mistakes with the feeding volume, techniques, and frequency because they have no prior experience. So it is our job to educate them and make sure they understand what is the right way to feed their babies. Thickened formula does reduce regurgitation, but for reflux episodes, not so much. When using xanthan gum-based thickeners, there has been some concerns for high viscosity and osmolarity shift. So we have to be extremely careful, especially for preemies and neonates. Up to 40% of infants with a problematic reflux, their symptoms are triggered by cow's milk protein allergy. Therefore, trying hypoallergenic formula is very reasonable, and try to avoid smoking exposure for babies. For older children, avoid consuming large meals and tell them not to lie down right after eating. And if they are heavy, they're overweight, they need to lose some weight, that will help. And avoid consuming acid reflux provoking diet, caffeine, spicy food, fatty food, and some do drink, so they should stop drinking and stop smoking. Let's talk about positioning therapy. Both pH probe and the pH impedance studies have shown that prone position and left lateral position reduce reflux activity significantly when compared to supine and right lateral positions. Look at this diagram. Pay close attention to the location of GE junction in relation to the air fluid level. In left lateral position, GE junction is much higher than the air fluid level. So what does that mean? It's a less transient LES relaxation, less reflux of gastric contents. In right lateral position, the GE junction is right at the air fluid level, allowing free access of gastric contents into the esophagus. So more transient LES relaxation and more reflux episode can happen. To summarize, we recommend the following. Infants should be kept upright at least 30 minutes after feeding, along with a head elevation 30 degrees. Both American Academy of Pediatrics and NASPGHAN agree that infants with a reflux should be placed in the supine position during sleep unless the risk of death from reflux is greater than the risk of SIDS. So that's the bottom line. So no prone position, no left lateral positioning for babies. For older children, we should definitely recommend left lateral position during sleep. That makes sense. And head elevation, and avoid lying down immediately after eating. We talk about that. When conservative therapy fails, we could consider pharmacological therapy. There are a few options we could choose from. Antacid neutralized gastric acid, they're commonly used for mild reflux symptoms, and it works. But since it contains aluminum hydroxide, a long-term treatment is not recommended in infants and children. Surface agents such as sucralfate or carafate is a coating agent, and it protects the esophageal lining, and it does work as well, but it does have the same issues like antacid, aluminum hydroxide. Both H2 receptor blocker and PPIs suppress gastric acid secretion. H2 receptor blockers inhibit histamine receptor on the parietal cells, and PPIs bind to the proton pump, and that is the final step in acid production. So both of them works, but PPI have much better efficacy than H2 receptor blocker. It's night and day. But do remember, H2 blocker has tachyphylaxis. So oftentimes it works in the beginning, later on it doesn't work. And let me show you this. slide. So this is the parietal cell, and you can see here is a histamine receptor, and this is how H2 receptor blocker works by going there and inhibit. And this is a proton pump, and PPI goes there and bind and inactivate the proton pump. And the last option is a prokinetic agent, such as metoclopramide and erythromycin, that we occasionally use them. Metoclopramide is a dopaminergic receptor antagonist, and it increases LES pressure and it accelerates gastric emptying. So that's good, but it has a very narrow margin of safety, and it could cause tardive dyskinesia. Erythromycin and other macrolide antibiotics are motilin receptor agonists, and erythromycin also has tachyphylaxis. Pyloric stenosis has been reported in infants who were exposed to erythromycin during early infancy, so we have to be careful. So because of this potential side effect, we don't use this medication routinely, okay? And this is a list of commonly used acid suppressors in pediatric populations. So it tells you that H2 blocker, PPI, prokinetic agent, and antiacid, and the dosing. I think PPIs are wonder drugs, as they do exactly what they are designed to do, as long as we are using it correctly. They provide excellent healing of peptic ulcers, controlling upper GI bleeding, and all of us benefit from this. As we discussed, pediatric gastroenterologists and pediatricians were using PPIs quite often with a good intention to treat babies with reflux disease, but not all of them require acid suppression. We talked about fussy, irritable baby does not always have reflux esophagitis. So there have been quite a few published studies looking into efficacy of PPIs in infants. So these studies show that PPIs, when compared to placebo, they were no better. So they did not reduce reflux symptoms in infants. And more importantly, they did not decrease irritability and fussiness in infants. It was disappointing. So I think there are two possible explanations why it did not work. Number one, true erosive esophagitis in this age group is rare. Number two, a large portion of reflux events in this age group are known to be non-acidic. Hence, acid suppression doesn't work. So here it said, stop the PPI express. They don't keep babies quiet. So this was an editorial in the Journal of Pediatrics in 2009. You know, I like this title. So we should keep in mind, it's not for everybody. So I'm going back to this again. Are we over treating reflux in babies and over prescribing PPIs? Yes. There are growing concerns over risks associated with the PPI use. And there are many studies, mainly in adults, supporting these concerns. I believe there is a paradigm shift in how we manage simple reflux in infants. We need to know when to use PPIs, when not to use PPIs. So the indication for PPI use are erosive esophagitis, NSAID prophylaxis, GI bleeding, PPI responsive eosinophilic esophagitis, and H. pylori eradication. So we should stick to this indication as much as possible and try not to deviate from this. There are limited pediatric data when it comes to potential risks of long-term PPI use. This is what we know so far. Children exposed to PPI therapy often develop C. diff infection and other enteric infections such as Campylobacter, Salmonella, Shigella. And SIBO is more common among long-term PPI users than patients with IBS. Both PPIs or H2 receptor blockers may be associated with community-acquired pneumonia, as well as hospital-acquired pneumonia. Necrotizing enterocolitis and candida infection have been reported in NICU patients. Iron absorption, calcium absorption, vitamin B absorption require gastric acid. And long-term PPI users develop hypochlorhydria or achlorhydria. So because of that, PPI users develop iron deficiency, hypocalcemia, vitamin B12 deficiency. And PPI-associated low magnesium levels has been reported in adults, but not in children. And we don't know the exact mechanism for that. PPI use has been associated with interstitial nephritis, and I'm not aware of any pediatric case. There are ample adult data supporting association between PPI use and the risk of fracture, especially hip and vertebral fractures in older people. So far, there are very limited pediatric data on this topic. I found one study from Walter Reed Hospital, that's in Bethesda, Maryland. This study was published in 2019. It was a retrospective cohort study of almost 100,000 children who were prescribed acid suppressors, both PPIs and H2 receptor blockers. So the summarized findings are, number one, the risk was higher, risk of fracture was higher when PPI treatment was initiated before 6 months of age. And the risk of fracture increased with the length of treatment, meaning it's dose dependent. Longer you're treated, more likely you could have a problem. PPI initiation after 12 months of age was not associated with a fracture. H2 receptor blockers were not associated with a risk of fracture. So this is something to remember, but this is only one study showing the risk of fracture in children. We clearly need more data, and the jury is still out on this. Currently, NASPGHAN and AGA guidelines do not recommend doing any screening blood test or DEXA scan for PPI users. Next, let's talk about microbiome, okay? So given the reported higher risk of C. diff infection and other enteric infections among PPI users, microbiome composition in this population was looked into. And as predicted, there was a gut microbiome changes in this population. They had reduced diversity of bacteria and increased pathogenic bacteria. But what's surprising about this result was the changes associated with PPI users were a lot more remarkable than changes associated with the antibiotic use. I think that's huge. When medical therapy has failed and the patient or the family is not quite ready for fundoplication, transpyloric feeding tube placement, also known as post-pyloric feeding tube placement, can be considered. It could be either NJ tube or GJ tube placement done by interventional radiology team. Feeding into the proximal jejunum does reduce acid reflux by bypassing the stomach, and it is much safer for patients with aspiration issues. But we have to be mindful that tube dislodgement is a common occurrence, and the patient ended up requiring frequent tube replacement by IR. It's no joke. So when do we consider anti-reflux surgery? When patient failed medical therapy, when patient is dependent on aggressive prolonged medical therapy, or patient is not following their medical therapy, so they don't take their medicine. Patient has a persistent asthma or other respiratory symptoms, or life-threatening complication of acid reflux, reflux disease, then I think surgical management has to be considered. Fundoplication is a wrapping of the fundus around the lower esophageal sphincter. The main objectives of this surgery are to restore the intra-abdominal portion of the esophagus and reduce hyperhernia when present. So, summary. Reflux is common in healthy infants and usually resolved by 12 to 18 months of age or sooner. Good history and clinical judgment are important for optimal evaluation and management. What diagnostic test and what treatment options we would consider all depends on patient presenting symptoms and signs and how severe they are. Acid suppression therapy should be used only when indicated. We have to use this medication carefully and judiciously. So this concludes my talk. I have prepared 4 questions for you. Don't worry, no trick questions there, okay? So first question, Kimberly?
Sorry about that. My sound was. Oh. Can everyone hear me and see me? It says I can't start my video here.
I could hear you.
Okay, so I'll just go over the questions. So, which of the following symptoms of gastroesophageal reflux is more, oh, it's going out again. Okay, so sorry. Okay. Which of the following symptoms of gastroesophageal reflux is more common in older children and adolescents than in infants and young children? Robert has set up where you can choose your answer. So is it number 1, apparent life-threatening event? Number 2, heartburn? Number 3, failure to thrive? Number 4, feeding difficulty? Or number 5, regurgitation? And we'll give you a few seconds there to make your choices. And then Dr. Moon will tell us our answer and explain why. All right, has everyone sent in their vote? And Dr. Moon, what's the answer
Okay.
to that question?
So correct answer for that is number 2, heartburn. We covered this during my presentation. So OT, failure to thrive, feeding difficulty, regurgitation, they are more common in infants than older children. As I mentioned to you, older children and adolescents, their symptoms are very similar to symptoms of adults. So you're correct. Yeah, that's good. And the next question is?
Okay, a 5-day-old term infant is seen in the clinic for an episode of choking at home that was associated with emesis. Which of the following statements regarding gastroesophageal reflux in newborn infants is correct? Is it Gerd in this group, pathological phenomenon? Is it Gerd? Is it differentiated from Gerd when there are signs or symptoms such as significant discomfort, poor weight gain, esophagitis, or airway symptoms? Number 3, most infants have a peak in reflux symptoms at 1 week of age, with a steady decline to no reflux by 1 month of age. And lastly, number 4, reflux in this group is most often caused by transient relaxation of the upper esophageal sphincter. We'll give you a few minutes to submit your answers. All right, Dr. Moon.
Okay, so I think the answer here is number 2. I think, yeah, a lot of you got it right. So girl in this age group is physiologic, most likely, not pathologic, because we're talking about young babies, right? And number 3, why is not correct? Because the reflux tends to peak around 4 to 6 months of age, that week, 1 week of age, and it declines, 7 months, and I actually got, remember that graph, go down to 5%, 10 and 12 months of age. So that's wrong. Reflux in this age group is most often caused by transient relaxation of lower esophageal sphincter, not upper esophageal sphincter. So that's incorrect. Okay.
Awesome. We'll go to question number 3.
Yes.
All right. Who has recurrent asthma exacerbation is brought to the clinic by his mother, who's frustrated by his frequent wheezing episodes. He's been gaining weight lately from 50% last year to 75% this year. Reportedly, he likes to eat McDonald's and plays video games several hours per day. His lungs are clear bilaterally, and the remainder of his physical examination are normal. You suspect that reflux may be contributing to his recurrent wheezing episodes. Which of the following is the most appropriate next therapeutic intervention? Would that be daily antacids therapy, dietary changes and regular exercise, daily erythromycin therapy, daily famotidine therapy, or daily omeprazole therapy? We'll give you a few minutes to get your answers in. All right. Dr. Moon, our answer should be coming up here shortly.
Yeah. Okay, good. So many of you got it right. So yes, it is number 2. I mean, listen to this story. I mean, we've heard this a lot during pandemic lockdown. You know, a lot of kids don't go to school and they're just sitting at home and play video game. And yeah, so this one, he had a rapid weight gain during that time, and he's eating junk food, and he has a sedentary lifestyle with a lack of physical activity. But despite all that, he's physical exam is good. So I would not start any medication as a first choice. I think, we talk about reflux management should be step-up approach rather than top-down approach. So dietary change and regular exercise, and maybe he needs to, lose some weight. That will help him. Okay, so last question.
All right. A concerned mother of a 5-month-old infant brings her daughter because of frequent spitting up after feedings. She denies respiratory difficulty, apnea, cyanosis, or coughing with episodes. She's frustrated because she constantly has to change her daughter's clothing because of frequent spitting up. Her current feeding includes 1 serving of baby food and 30 ounces of regular cow's milk formula per day. The infant's weight and height are at the 50th percentile. She appears alert and happy, and findings on physical examination are normal. Which of the following is the most appropriate step in management? Number 1, discontinue all baby foods until spitting up resolves. Number 2, start prokinetic therapy such as erythromycin. Number 3, order an upper GI series. Number 4, reassure the mother that her baby is healthy and spitting up should resolve. Or number 5, switch the infant to a soy-containing formula. Go ahead and submit your answers. We'll give you a few minutes here. And following us wrapping up question number 4, we'll go ahead and look into the chat and see if there's questions there that we could answer.
Okay, so yes, I think 68% answer number 3. I'm sorry, number 4. I do agree with that. I think in this case we are talking about happy spitter, she seems to thrive. So I would not be overly aggressive, as I mentioned to you during my presentation. But one thing I might consider, I think this, you could consider trying formula change. But the reason why number 5 is not correct, if I were to change formula, I would not try soy-containing formula, because approximately 40% of infants with a milk protein allergy also have soy allergy as well. So it's better to go to hypoallergenic formula rather than going to soy formula. So that's the reason number 5 is not correct answer.
All right, Dr. Moon, I think we have about 3 questions in the chat. So let me start with the first one. This is from Jeremiah Davis. To what extent infants constitute a portion of the increased PPI use in less than 2 years old?
In terms of, can you repeat the question for me?
To what extent do premature infants constitute a portion of the increased PPI use in less than 2 years old? So I'm assuming that's babies less than 2 years old or infants.
Okay. I think I could read the question here. So to what extent, constitute a portion of increased PPI use in 2 years old? Jeremiah, can you elaborate a little further? I don't understand what your question actually. Could you?
Maybe it's the incidence.
I don't have that answer in terms of incidence of PPI use in preemie infants. I'm not sure we have the data.
So Jeremiah said you quoted an increase in PPI use in the past few decades.
Oh, so you're referring to that. I think basically one paper said there's a 7.5 fold increase in PPI use between 2000 to 2004.
Okay, let's go to Francisco Bravo. What is the IPB that you prefer to use in the treatment?
What's IPB? Tough questions.
Francisco, can you tell us what you mean by IPB? And just for further questions, it may be helpful to just spell out the name. Okay, while Francisco's working on that, how about we go to the next few comments and questions. The first one is, can we get a copy of the slides? And so Ruth is going ahead and answering that. When should we use soy-based formula?
One good indication for that is galactosemia babies needs to be on soy formula for sure. Other than that, I think, it's reasonable to try because of, there's a 50% chance that the baby might do okay because it's a 40 to 50% have a cross reaction. So if you say, I'm going to see how baby does on soy first, then go to hypoallergenic, I think that's reasonable too.
Okay. All right. When babies are introduced to complementary foods too early, is there an increased incidence of reflux? And the last case example poll question, would discontinuing baby food and waiting until 6 months of age help?
Yeah, I think 5 months is not too early for introducing semi-solid. In generally, to me, is anywhere between 4 to 6 months is the optimum time to have semi-solid introduction. So I guess it's, you could consider doing that, but I think this case, better to continue to offer some food and rather than stopping it.
Great question. Does your GI group have families do thickening or formula, or I'm sorry, thickening of formula or breast milk? If so, what do you use and how do you use this?
Yeah, I think there are two types of thickeners. I think one is a starch base, which is a rice cereal. The main problem with the thickening breast milk is the breast milk has enzyme, so it's really hard to thicken breast milk. So you have to be careful with that. We do use thickeners such as gel mix, but I did mention to you earlier about the xanthan-based thickener can be associated with the issues in preemies, so you have to be careful.
Really good questions. Okay, our next question, is there less GER or GERD with breastfeeding with no formula use?
It depends. Sometimes milk protein allergy in the breastfed baby, if mom is consuming dairy product and soy product, and they could have a lot of symptoms. In that case, switching babies to hypoallergenic formula makes sense. And I'm sorry, prior to that, you could change mom's diet first, then consider hypoallergenic formula if that doesn't work.
All right, we have another one here. If you decide to try PPI for a young child, Gerd suspicion, how fast can you expect to get results or symptomatic relief?
Yeah, I would say within 1 week, you will definitely see some improvement. Typically, I give my patients, tell them, try 1 week, but don't stop the medicine, before you're trying at least for 2 weeks. That's my answer.
All right. Next question. What is the proton pump inhibitor that you prefer to use in the treatment?
I think that's actually insurance is the one dictating. So we often use omeprazole, lansoprazole, but all depends their insurance covers.
Okay, do you give a probiotic with starting PPIs? And what is the best strain?
I have not, but I think the papers I read, I think they start to suggest anybody who's taking PPI for long term, they recommend probiotics, and obviously lactobacillus, those common things can be reasonable. But personally, I have not started yet.
Is there typically issues with rebound and production after stopping PPIs and rebound acid production after stopping PPIs in infants?
I think it's all age group. I think theoretically there's an acid production rebound is expected. So even after 2 weeks of therapy with a PPI, they do expect that the acid production goes up.
All right. Beyond hypoallergenic ones, what do you think about the effects of thickened, especially carabine formulas?
Yeah, so we do use gel mix.
I'm sorry, Dr. Moon, can you repeat that?
That's gel mix I mentioned to you earlier. Carabine, that's a gel mix we use, and we do use that for thickening of formula, or there's a recipe to concentrate the powder formula by adding less water. That's another way to do it.
Okay. What kind of diet do you suggest for the breastfeeding mother with a baby with reflux?
I think I covered this briefly. If I suspect there's a milk allergy component, clearly I would ask mom to eliminate dairy product and soy product and see whether baby symptom improve on that. Okay, I think that's it.
All right. Dr. Moon, this was an excellent, informative presentation, and we really appreciate your expertise. Thanks to everyone for attending, and hopefully this will help guide some of your practice. As we stated at the beginning, Dr. Moon is an expert in this area, so the slides will be available for you, and thanks again for joining.